Good evening, everyone, and good afternoon to some of us, and good morning to our friends in the Global North. My name is Amos Juguna, and it is my privilege and great pleasure to welcome you to the 2021 Africa Evidence Summit. This summit is co-hosted by the Center for Effective Global Action, CIGA, Development Impact West Africa, DIWA, and the Network of Impact Evaluation Researchers in Africa, NERA. We are delighted to have you in this noble event. Every year, the Africa Evidence Summit brings policymakers, researchers, and development practitioners to promote evidence-informed policymaking in the region, a pertinent goal that we are committed to advancing. It is a goal that I know we all share and are seeking to advance through our distinct areas of operations. The theme of this year's summit is inclusion in global development research. With us today are leaders, development practitioners, and researchers who will share their experiences and perspectives on achieving inclusion in the development sector. Allow me to briefly introduce the network of impact evaluation researchers in Africa in a few minutes. NERA, as we are popularly known, is a network of East African scholars that seek to advance decision-focused evaluation of social and economic development programs. At the moment, we have a membership of 32 alumni of the East Africa Social Science Translation Collaborative East, a multi-institution research network that is administered by the Center for Effective Global Action that's hosted at the University of California in Berkeley. That is where my colleagues, Carson, Maya, Chelsea, are based. And Carson and Maya will later talk about this interesting network that is really, that we are proud of as the mother of NERA. The membership is spread across 5 countries: Tanzania, Uganda, Rwanda, and Kenya. Each member of NERA is expected to promote decision-focused evaluation and use it to inform policy and practice. This we do through capacity building efforts, generating evidence using rigorous approaches in research, and policy outreach and communication. Each member of NERA, therefore, is based in an East African institution and is actively involved in these activities. The network is currently hosted by the United States International University in Nairobi, based here in Nairobi, Kenya, and broadly its work revolves towards entrenchment of specific activities that then contribute to the overall mandate. I sincerely hope you will enjoy the next 2 days of debate and networking that we will be having. So I officially welcome you to this virtual summit. Of course, in the recent past, the previous 8 engagements have happened on face-to-face, but due to the difficult times, we will be engaging virtually for the next 2 days. So I look forward to interacting with you and chatting with you and listening to interesting presentations that will be made. I've had privilege to go through the agenda, and I've seen quite a number of very interesting activities that will be taking place in the next 2 days. So with that, I will invite my colleague, Carson, who will then take you through CIGA and welcome you to this very important event. Thank you.
Thanks so much, Amos, and hi, everyone. Good morning, early morning to my colleagues in California. And as Amos said, good afternoon and good evening to all of our colleagues in Africa and to other parts of the world. I'm Carson Cristiano. I'm the Executive Director of CIGA, and I'm so delighted to join Amos today and welcoming you to our 9th East Summit. I didn't say annual because unfortunately we missed 2020 for obvious reasons, but hopefully we'll get back on track very soon. I'm truly sorry that we can't be together in person, as this event is always great fun with so many new and old faces. But with the world, or at least parts of the world, getting vaccinated now, I'm optimistic that we'll see each other again soon. Before I hand it over to Maya Ranganath, who runs SIGA's Global Networks programs, including EAST, which Amos is an alumni of, I want to tell you a little bit about SIGA. So the Center for Effective Global Action was started almost 13 years ago now by a small group of economists at the University of California, Berkeley, who were excited about the idea of applying empirical quantitative methods to the study of poverty and economic development. And now today, SIGA is a network of over 140 faculty based at universities all along the West Coast of North America, along with hundreds of PhD students and 25 program staff, including Maya and Chelsea, who run our Global Networks program, based at UC Berkeley. Our affiliates work with collaborators from diverse backgrounds all over the world to tackle important policy questions using rigorous evidence. So questions like, how can we design financial tools to better empower women? Or how can we help governments deliver cash aid to beneficiaries who need it most? How can we help smallholder farmers be more resilient in the face of climate change? And you can imagine an infinite number of questions that we could address with rigorous evidence. Our affiliated faculty at SIGA come from a wide range of disciplines, and they use a wide range of tools, including randomized trials, quasi-experiments, and data science approaches. All of them share a common desire to better understand the root causes and consequences of poverty and the effectiveness of promising solutions. And one thing that I'm very proud of is that from the beginning, SIGA has been committed to inclusion, to working closely with local collaborators, including African researchers, to identify the right questions, to connect with the right on-the-ground partners, and to ensure that the evidence we generate translates into effective global action, which are the last 3 words of SIGA's name. Our fellowship programs, which Maya is going to tell you more about in a moment, are so important to SIGA because they make our network and our impact truly global. The talented African scholars who have participated in our fellowship programs, our events, and our research grant competitions are changing the way that social science is practiced on the continent. They're really helping to establish a culture of evidence and evidence-based policymaking that goes far beyond what SIGA could accomplish on our own. So I want to thank Amos and Niera and all of the African researchers who have joined us today, our partners at GIMPA and other institutions. Whether or not you have already participated in one of SIGA's Global Networks programs, I hope that you'll learn something from the talks and networking sessions and maybe come away with some new research ideas you might want to pursue. If you're a policymaker, I'm very honored to have, and I'll introduce later, Professor Ezra Saruma from Makerere, who also works with the government of Uganda. And I know that we have several other policymakers here at the summit. I hope that this event will give you some new insights, will inspire you to use evidence in new ways, and maybe even reach out to Niera or to SIGA to collaborate on future evaluations. If you're a practitioner, I hope this summit will get you thinking about new kinds of data you might collect and possibly even experiments you could run to better understand the impacts your programs are having on people's lives. And last but not least, if you're a funder, I hope you'll come away feeling really excited about the opportunities to support African-led impact evaluation research, as well as research being conducted by members of SIGA and our extended network. I really think that it's a good investment. And with that, I'm going to hand it over to Maya, who's going to tell you a little bit more about SIGA's Global Networks programs.
Thanks so much, Carson. I'm just going to present. Okay, hopefully everyone can see my slides. So good morning, good afternoon, good evening, everyone. I'm going to give you just a brief overview of what we mean by inclusion in global development research and an overview of SIGA's programs in this space. Oops. Okay, great. So this is a quick overview of what I'll talk about today before we move on to our keynote from Dr. Ezra Saruma. So let me just start with the issue here. I think that many of us in this room have seen these statistics before or have heard about these issues, but it's worth highlighting here again. So this statistic is really stark, that only 1% of the world's research outputs of the world's research outputs are produced by African scholars. So obviously, compared to the population of Africa, this is an extremely small amount. And when we move to the field of economics, which is what most of us work in, less than 8% of publications on Africa in top economics journals have an African co-author. So I think this quote from a recent article succinctly summarizes why we care about this and why this matters, is that knowledge is power, and the creators of knowledge are controlling power in a way. And so when we think of our global power dynamics and our post-colonial world, adding to knowledge production is of paramount importance and improving this space. So I think that we are in the midst of a global reckoning on this. There's been a lot of articles that are coming out, a lot of major journals are paying attention, a lot of scholars and other folks in the space have come out with critiques about this and are trying to discuss how do we move forward. And I think this is the start of a really positive reckoning. And this leads to, I think there's some good news. Here's Amos on the right at our last East Summit in Kenya. But there's many of you in this room who are part of this efforts to build up capacity of research, to link up researchers and change norms in the global development research space. And scientific output in sub-Saharan Africa is actually growing based on a new study that showed that it grew close to 40% between 2012 and 2016. And an exciting study by Hewlett and the Africa Evidence Network found that there's actually quite a lot of capacity in impact evaluation. Based on a study they conducted, they found about 1,500 researchers in many different countries that have authored or co-authored impact evaluations. And so I think this is all promising in our space, and it's showing that we're heading in the right direction. There's still some key challenges. This is not an exhaustive list, but these are the problems that we've been focusing on at SIGA, and they are that African scholars have limited funding and sometimes the incentives to conduct rigorous impact evaluation research. There's sometimes limited access to networks, resources, and information challenges, as well as the overall research infrastructure, which includes training, coursework at universities, and access to data. So a little bit about SIGA and our partners' approach. So we offer these core activities across several programs, which I'll get into in a second. So the first is we offer fellowships for African scholars to come to UC Berkeley to register in classes in economics and do another coursework related to rigorous impact evaluation, including courses in public health. We have several of our fellows here today. And so they form like a really robust network of people who go on to have access to our research training and policy engagement grants. And so these are grants, we give out research grants of about 50K. I think several of you here have received some of these grants for US collaborators and African collaborators to work together to answer a question of importance through using rigorous research. We also give out training grants and small grants for our fellows to go on to engage policymakers and other academics at their institutions in training activities. And I should mention that, and I'll make this link to MIERA after, but those who've come through our fellowships through the EAST program go on to become members of MIERA. And so there's a really, really close link between our two organizations. And the last core activity that we do is we organize conferences and have research workshops. So these conferences, such as this one, are great spaces for both US researchers and Africa-based researchers to come together, to learn from each other, to discuss the latest insights, and to really provide a space for networking so that we can think about future collaborations. We also organize other research workshops. During the pandemic, we've been organizing the SIGA Global Workshop, which features US researchers and African researchers side by side in a virtual seminar series. And we also do other workshops for people to receive feedback on early stage work, both from African scholars and from US-based scholars. So these are our core programs, and I should mention that we're really happy to and honored to have funding from the Hewlett Foundation, from IDRC, and from the NIH's Fogarty International Center for these programs. And I'll take you through a really quick snapshot of each program, which is each one, they're all interrelated and they all touch on the similar activities that I was just talking about, but with slightly different contexts. So EAST is our longest running program. Several of our fellows are here today. Usually we call this event the EAST Summit, but we wanted to expand it given that we're working in other geographies now as well. But EAST has been around for 12 years. We actually started at a summit in Kampala with Makerere University. So it's even more special that we have Dr. Saruma as the chancellor here today to start us off. So EAST is a multi-institutional research network, as Amos mentioned, that provides fellowships for East African scholars, and we organize this event, and we also have conducted several research studies together with East African scholars and co-authors. So then we have the BRAC-SIGA Learning Collaborative, which is a partnership between the NGO BRAC, that's both in Bangladesh and in East and West Africa, and SIGA, to both help BRAC with its research capacity as an organization, but also through trainings and other events, but also through having SIGA faculty collaborate with BRAC researchers to evaluate BRAC's programs. So that's a really interesting project that we're excited about continuing. And then we have DIWA, which is one of our newest projects, we're very lucky to have Dr. Charles Amoate and Richard Otu here, who are really taking the lead on this project with the Ghana Institute of Management and Public Administration. So this is a collaboration between SIGA and GIMPA to invest in early career researchers in West Africa. And this project has a very strong policy component where almost every one of the research projects we funded is coming directly from a policymaker's stated demand. So we're very excited to work so closely with policy, and really thrilled by GIMPA's leadership on this project as well. And then one of our new initiatives as well is the Impact Evaluation Evidence for Decision Making Lab, which is led by Kizito Amala and Ronald Mulabeke, who are two of our past fellows. So Kizito is in the School of Statistics, and Ronald is in the School of Public Health. And this lab in Makerere really brings together these two schools and brings together SIGA to collaborate on research studies that are of importance to policymakers in Uganda, as well as training events for Makerere faculty and curriculum development on impact evaluation at the university that SIGA is assisting with. Many of you, I think, have come to Wagape, which is a very old program started in 2002 by Ted Miguel, our faculty director, and Dan Posner. And this program brings together Africa-based and US-based researchers to give each other really in-depth feedback on African political economy issues. So it's a really exciting event that takes place several times during the year. So definitely get on their mailing lists and be aware of that program. And that program has recently started making small grants to African scholars. So we're very excited about that. And another new thing that we're doing in collaboration with Stockholm universities and several other universities in both the US, Europe, and Africa is the remote student exchange. And so this program really is an experiment that's taking advantage of the fact that so many courses being offered in high income countries in both the US and Europe on economics and several other fields are now being conducted online. And so these researchers had the idea, what if we opened up those classes to students from all over the world? And so we're just piloting what this could look like to select students to enter into these courses, and we're excited to see the future of that. So I can't go any further really without mentioning our partners. As Amos mentioned, we're so proud of NIERA, who's come out of the idea for NIERA really started organically from our fellows at the 2017 East Summit in Addis Ababa, and we've been working with them as close partners ever since. We've organized every summit together with them, including this one. And and really are excited about the directions they're going in. We also have worked with APHRC for a long time. We're working with Makerere, with the Economic, Social, and Research Foundation in Tanzania, as well as GIMPA, who I just mentioned, who are all of our key partners. We also work with other institutions globally to promote capacity building and inclusion and help thinking through how to set up programs similar to ours. So I'm excited for tomorrow, where Carson will moderate a panel that'll feature several of these people discussing their work and their perceptions on African-led impact evaluation in general. Usually this East Summit, or the summit, is so exciting because all of you get to meet our East Fellows and everybody gets to talk to each other and get to know each other. But since we'll get to do some of that in the networking session tomorrow, but just to give you a quick introduction to all of them, many of whom are here, I'll just run through these slides so you can get a sense of their of who they are. So we're really grateful for all of them in our network. And so here are our Ethiopian fellows, our Kenyan fellows, Tanzanian, Ugandan, and our Rwandan fellows. So a big virtual applause to all of them. And before we move on to Dr. Saruma, just a couple of our impacts and looking forward. So we've had several impacts that we're really proud of through our programs, and several that we are still tracking and that we are not sure of yet, because our programs represent really long-term investments and will take time for us to fully realize the impacts. But so far we've had 47 visiting scholars at Berkeley since 2012. So this includes both BRAC fellows and East fellows. And we're happy that we'll soon be having fellows from West Africa come as well, hopefully this fall if things are fine by then. So this will be, represents our new cohort. These fellows have gone on to train over 1,000 people in impact evaluation methods and are going on to do that even more through NIERA. So this figure represents our direct training grants that we give up, but the actual figure is quite a lot higher. We've done about over 50 collaborative research projects in 13 countries that have been funded since 2013. So these projects are mostly smaller grants, but we've seen them as impactful ways for people to work together. And we're right now in the middle of a process doing a whole review retrospectively of most projects we've funded, and doing in-depth interviews with the recipients of our grants to see if there were policy impacts and long-term studies. So we are looking forward to the results from that study. And many of our fellows continue to collaborate with their mentors at Berkeley and publish in prestigious journals with them and without them afterwards. And we've also given out policy engagement grants, which NIERA, I will say, mostly handles a lot of this piece of it now, but we've also supported over 20 partnerships between researchers and policymakers, which are things like embedding a fellow at an M&E unit, just like our fellow Annette Adong was embedded at the Office of the Prime Minister in Uganda. And we've had other examples of that, or working to scale up a project to hold stakeholder convenings. There's a lot of different creative ways people have used these funds. And we've also had many examples of our fellows' research informing local policy changes. So I won't go into those now, but some of those are on our website. And if you're curious about that, we can also talk a little bit further about policy impact during our panel tomorrow. So a little bit about the future. And I've touched on some of this, but we've been thinking through more, how do we use virtual realms to enable scaling of our programs? So our programs focus on very in-depth investment on a few people. And so one way to expand this is perhaps by doing virtual fellowships that wouldn't replace our in-person fellowships, but would provide an alternative to people. And we're already getting this started, where we will remotely pair people with a mentor, and they will go through a virtual version of our program. And then the other one is, of course, the remote student exchange, which I mentioned is opening up classes to students from all over the world. We're excited to see how our model can adapt to other geographic contexts. We've worked mostly in East and West Africa, but we'd like to see what are the demands and opportunities in other places to do this kind of work. We're really, really focused on partnerships. We are interested in having even more partnerships with African institutions and also helping other organizations who would like to mainstream inclusion into their work as well. We're happy to collaborate with them. Yeah, and so that's one last. So this is a couple pictures of our summit in years past. I've been around for, I think, 4 of them in country, and this is my 5th one. So we are sad that we can't all be together, but really, really grateful that you all are joining us today. And hopefully we'll see you all in person in the future. So a little bit of an overview. So thanks so much to Amos and Carson for giving us our open remarks. Next, we'll have our keynote address from Dr. Saruma, and Carson will introduce him right after this. We'll take a quick break and then move into our first research session where we'll have Ted Miguel and Jane Tusime present their research and along with their policy discussants. And we'll have a few 5-minute rapid lightning talks on health. Tomorrow, we'll start out with the panel that I've been referencing, which will feature several institutions. It'll feature ESRF, NIERA, GIMPA, and I think a few others. And Partnerships for Economic Policy, PEP, and will be moderated by Carson. And we're hoping to really dig into these issues that I presented at the beginning in that panel. We'll have another research session where we'll have Anthony Wayange present his research on COVID. And Chelsea, I think you'll post the link to the agenda in the chat, right? So you can all reference the agenda. And we'll also have Josh Blumenstock presenting his work using data science methods and to target humanitarian assistance. And then we'll have several lightning talks focused on gender and education. And there's also going to be an optional networking session, which Chelsea sent out information about, but she'll also include more information in the chat of how to sign up for that. So a few guidelines. So you're all muted by default, but we really, really encourage you to engage and to ask questions. So during the Q&A for each session, type your questions into the chat or use the raise hand feature in Zoom to ask a live question and the moderator will unmute you. If your bandwidth allows it, we would love to have your videos on, but if not, of course, that's fine. SIGA has a strict code of conduct for our events. So we don't tolerate any harassment, and just please let me or another SIGA staff member like Chelsea or Dustin or Carson know if anything makes you feel unsafe or unwelcome during this event. So I'll pass this on to Carson now to introduce Dr. Saruma.
Thank you, Maya. So hello again, everyone. I guess let's spotlight Ezra as well. I am delighted now to introduce our keynote speaker, Professor Ezra Saruma. And rather than have Professor Saruma deliver formal remarks, we've decided to have a conversation about the role of evidence in policymaking in Uganda. I think you'll see from his bio why Professor Saruma is the natural person to be having this conversation with. He is the Chancellor of Makerere University, a distinguished scholar and statesman with a wealth of experience in the field of finance and banking spanning more than 25 years. Professor Saruma serves on the board of the National Planning Authority in Uganda. He participates in numerous national and international economic policy discussions and initiates proposals for policy change. He's the head of the Prime Minister's Delivery Unit, responsible for the implementation of priority programs in the Ugandan government. And Professor Saruma has a doctorate in economics, which he obtained from the University of Connecticut in the United States. He also has a master's in economics and a bachelor's in finance, both from Fordham University in New York. So quite an impressive CV, and I think we're excited to talk to him because of his experience that spans academia and policy making. So Ezra, I think you told me that I could call you that. Welcome, and thank you for joining us today.
There
you go. You're off
mute. Can
mute.
you hear me now?
Absolutely, yes. Thank you for joining us.
Thank you. Thank you very much, Cousin.
So you've been a lot of things: a professor, a banker, a minister of finance, and a senior advisor to the president of Uganda. And now I understand you work to create policies that affect millions of Ugandans. So I'd love it if you could tell us a little bit about what that role entails, and what are the policy issues and priorities that are most important to you or have been most important to you personally?
Thank you very much, Cousin, and thank you all for inviting me to this program. I am not sure I'm qualified to be here, but since you invited me, here I am. It's a pleasure to join you all. The Prime Minister's Delivery Unit was created about 5 years ago as a result of the big gap between policies and implementation. Many policies were being made. We thought they were good policies, but when we would look at how many of them have been implemented, we found that few were being implemented. Those which were being implemented were not being implemented well. So there was an outcry going on for a long time on what can be done to close this gap between policies and implementation. So the Prime Minister's Delivery Unit was created in 2015. I'm the head of it. And our focus is on government priorities, identifying the priorities of government and ensuring that those priorities are implemented. Now that can be a very big task. When the unit was formed, I was asked to have a discussion with all the permanent secretaries. These are the heads of civil servants in every ministry, every sector. And in that meeting, everybody thought their sector was a priority. So we couldn't go very far. No one would agree that certain areas which we're talking about should be prioritized over others. So that's one fundamental problem we face, agreeing and continuing to agree that something is a priority, and that's what we should attempt to implement. But we take it that while sectors may think that their areas are priorities, there is only one government at a time. There's only one head of state at a time. And so if the head of state says that this is a priority, we try to stick to that. So basically that's what we are doing to implement, to improve service delivery in key areas or in priority areas of government.
Thank you. I know that it won't be possible to go into too much detail about what you're working on now. Are there issues that have been major priorities? I know your background is in finance. Priorities for you personally in the past?
Well, in the past, yes. But,
I know that you work a lot on microfinance in Uganda. I saw that in your bio.
When I became Minister of Finance in 2006, my first order from the president was produce a policy on microfinance, on how to include more people into the financial sector. I had done a great deal of work on reforming Uganda's financial sector, but that was for the big banks, which tended to be mostly in the towns. But in the rural areas, there was hardly any financial services. And so I worked very hard consulted a great deal to find out the best policy for increasing inclusion. And we did establish a system of savings and credit cooperatives, which I must say have done a great deal in increasing inclusion or increasing the number of people in the financial sector. There was a problem. I left the ministry in 2009 before the regulations for those savings and credit cooperatives had been implemented. For some reason, it took a long time to put regulations in place. And as a result, many of the microfinance institutions failed. They would steal people's money, but now that has been done. We have a regulatory system in place, and financial inclusion is definitely increasing. Of course, with the coming of mobile money, that has also helped to increase people who are participating in the formal monetary sector.
Yeah, that's great. Financial inclusion is an issue that's very important to SIGA, and we're doing a lot of work to try to generate more insights in that area. And I know, Ezra, that you care about evidence. We have an MOU between SIGA and the PMDU and are working on a few projects together. Can you talk a little bit about the role of evidence in helping you as a policymaker address some of these issues? What kind of data and information do you look for when you're trying to make a decision about policy? I know you mentioned politics are a very big part of this, so let's momentarily put politics aside, if we can.
If we can.
If we can.
Yes. I think one of the distinguishing characteristics of the Prime Minister's Delivery Unit is dependence on what we call real-time data. We collect, for example, we are now working on improving the quality of education in primary schools, government-run and government-owned primary schools. And we found that over almost a decade, only half the pupils after 6 years of education were passing literacy tests, and about 70% were passing numerous tests. So we wondered, why is it that after so many years, pupils are performing poorly in reading and writing? And we found that we collected some data and found that on average, teachers were absent 40% of the time, which was a frightening number. And so we thought that we would start by attempting to improve on teacher attendance in school. And that's what we've been doing over the past several years. Similarly, we are working on health worker attendance in health centers and hospitals, where the actual absenteeism is higher than in education, believe it or not. And this, of course, has major implications for patients, people who come to hospital and find that the health workers are absent. So in all these cases, we have to put in place a system for collecting data on who is present and who is not present every day. And we couldn't do it for the whole country. We don't have the resources. We started with 20 districts of Uganda. That's involving about 2,000 schools and 20,000 teachers or so. And the health workers, I think we have about 250 hospitals that we are working on. And every day we have to collect data. We're doing this manually, getting a record of who was present and who was not every day from the people in charge of the hospitals and headmasters in primary schools. Then we moved, with the help of DFID, we moved into biometrics. for the hospitals. And so we are beginning, it's a new challenge that we are facing. We're hoping you, when you come in, you'll help us try to make that system work. And so real-time data is essential for us to make our policies work, to make sure that teaching is taking place, that patients are being taken care of. And we are expanding now to an additional 20 districts. We have a grant from the World Bank to do that and to acquire more equipment, computers and servers and so on, so that we are able to get this data. Without it, we cannot implement these policies for service delivery. I don't know if that answers your question.
That's perfect. That's a really interesting example. And we're, of course, very excited to be working with you, at least in some capacity, on this project and trying to understand, what the effectiveness of using these biometric devices might be in boosting health worker attendance. And I'm sure that you have, you're talking about a massive data collection effort. So is a lot of that done internally? You contract out the data collection, the PMDU?
We are doing this, yes, in collaboration with the Ministry of Health. They had a grant from USAID for servers to collect the data. So we work with them. With regard to education, we are basically on our own, but we need a great deal of support. We're not as effective as we would like to be. We have a data department which focuses on how we collect this data and designing the systems and the software. And actually, we are in the process of expanding to cover, even to go beyond education and health. So the project is very big, and the requirements are enormous, but we hope that we'll be able to cope with it.
So Ezra, you have a virtual room here that's full of researchers, SIGA researchers, African researchers, and they want their work to be as useful to policymakers as possible. So you mentioned the value of real-time data, which of course is something that we can support on, but a lot of our research does take a bit longer, right? And so my question for you is, sometimes the research that's conducted generates insights among the academic community, but it doesn't always translate to policymaking. Politics was another factor that you mentioned that sometimes gets in the way of the translation of evidence to policy. If a policymaker is demanding something, and even if you maybe have read up on the evidence and you have an instinct about the right thing to do, sometimes you have to be strategic. But I'm hoping that you can talk a little bit more about the barriers that you see to designing and implementing evidence-based policy.
That's a tough question.
Yes, that's why I'm asking you.
Certainly, communication is very, very important. We find that there are maybe researchers who are really senior and have been at it for some time. They can communicate with us in language that we can understand. Many researchers are so sophisticated in their work, and when we try to talk to them, we can't understand what they are saying. So we can't use their knowledge. They are above our heads, so to speak. So being able to communicate, researchers communicate with policymakers is very, very important. Certainly, much of the communication occurs at the technical level, the civil service and government. My president does invite people from Makerere University, for example, from time to time. But even then, he will say, ask me to be in charge of them, because I have, over the years, I've learned to speak his language.
Yeah. Yeah.
So I would stress researchers being able to go from the work they do, which is highly technical, because that's what is expected of them in the journals and in the universities, and being able to see how that can be translated into the language that policymakers and politicians use. And that may not be so easy, but I found that the senior researchers, the senior professors are able to do that. They're able to take that, to cross over, as it were, from ivory tower to what we call the real world. And when they're able to do that, it helps a great deal. And I see an increasing evidence of collaboration between professors and researchers in Uganda and ourselves.
That's right. So this is something that SIGA and I know NIERA have been thinking about for a long time, is how can we both communicate our research in a way that's more digestible, but also how can we build partnerships in such a way that it maximizes the chance of that evidence getting used. And one theory that we have is that if we partner with policymakers, decision makers from the very beginning to design the study, that then the chances of the evidence actually being used for decision making is much higher. So that's exactly what we're doing with our partnership on, biometric tracking of health workers. We're hoping that by working directly with you to design that study, that the insights will be easier to understand, and you'll also be more likely to use the evidence because you're tracking the project very closely. Is that true?
So true, and so important that there is communication from the beginning, and the researchers understand the need of government. Of course, often the researchers want to do what excites them or what they like, and some of them don't even want government interference in their work, and that's understandable.
Yeah.
So, if where there is a mutual appreciation of the need in a country like Uganda, the need for poverty alleviation, the need for increasing agricultural productivity, for example, a need for increasing access to basic health. These are very, very basic needs that population have, and we are glad to have assistance wherever we can get it from, because the needs are so great. But still, you'll find that there are professors who prefer, maybe because they got funding from SIGA or some other organization or foundation, they are doing something that meets the requirements of the funders rather than ourselves, and our funding is a bit limited. So that is also another limiting factor on collaboration between us and academicians.
No, I really appreciate that point, and thank you for keeping us on our toes there. I mean, I think it's really important for us to think about what is motivating a study, and is it truly, set up to answer a real world question and the problem that is articulated and defined by the decision maker, or is it coming from somewhere else? And I think funders have gotten really smart about that. I mean, thankfully the funders that we work with really want us to understand policymakers' needs and build our research agendas around them. So hopefully you'll see a shift there. Ezra, I'm wondering, can you think of are there other examples of projects that you've worked on that you'd like to share with this group where you were able to partner with academics or or generate evidence yourself on a policy decision that was being made? I know that you've done a lot of work in the coffee sector, for example.
Yes, coffee is Uganda's biggest export. It has been for a very long time, the last 50 years or more. And so we've had to work very hard to have right policies. When the current government came in 1986, the earnings from coffee were the only funds available to sustain government, but we had a monopoly exporter called Coffee Marketing Board, which was government owned. And when the World Bank came to me, I was director of research at the central bank and suggested privatizing it. I said, no way. This is the only source of foreign exchange we have. We can't afford to have it in private hands. But with time, we realized that our policies were not right because the people, the farmers, started to cut down coffee trees. And we were absolutely alarmed. And I was asked to find out what could be done. So we worked with the World Bank. I traveled all over the globe, literally, to consult with other countries, coffee departments, and so on. And we had come up with a new policy and agreed to privatize coffee exports. Mm. And it had a dramatic impact. The coffee farmers, we used to wait for a year or two before they could be paid. They'll be holding an IOU from the Coffee Marketing Board, started to be paid instantly on delivery of coffee. And however, so there was a big improvement for the farmers. But when I was at Brookings in 1910, 11, after I left finance, Minister of Finance, I wanted to evaluate how well we had done in this area. Mm. And I was a bit shocked to find that our annual exports had stayed at 3 million bags per year for 50 years, even after we had done liberalization. Hmm. And I did not quite follow why. So recently, when the president asked our unit to look at options for increasing coffee exports 20 million bags from 3 million bags, which was a thorough order by 2020, I had to do huge consultations in the country and outside the country. We had to get the assistance. We did get the assistance of McKinsey and Company to do really a very long and very big lab with soil experts, with experts of various types of coffee and so on. By the end of it, I'm happy to say that now our coffee has already reached 8 million bags in 4 years, which had been at 3 million bags for more than 50 years. So yes, we have, I think, an experience of how consultations with a wide range of academicians and practitioners and so on, we call them stakeholders, I think, can actually have dramatic results. Another area I worked in was foreign exchange. We used to have very, very strict exchange controls. Mm-hmm. If you arrived in the country, you had to declare the amount of foreign exchange you had on you and submit it to the central bank within 48 hours. This was, of course, terrible, and no one could tell the truth under those circumstances, especially when the central bank would give you a fraction of what the value of the money was worth. So there was a huge black market in the country over foreign exchange. I led a delegation, again, a global delegation to so many countries to see how we could straighten this out. This was easier than the coffee, I think, because it became clear that it could be done relatively quickly. We had vested interests. People who didn't want it to be done because they were benefiting, but we overcame them. And this is more than 25 years ago. And Uganda's foreign exchange system, I think in the region, we attract a great deal of people from our neighboring countries and so on, because we have a free foreign exchange, liberal foreign exchange system, and where we feared that liberalizing would result in money flying out. Instead, it is the other way around, that money actually flies
Mm.
in. And I think on these two areas, I don't know whether you consider that to be evidence-based research. I really don't know. I did have to consult. I did have to get evidence that we could do it without endangering countries' foreign exchange or countries' coffee farmers. And there are many other examples, but those are the ones that I think excited me the most, which I think have had a lasting effect on the Ugandan economy.
Mm-hmm. No, that's great. Thank you for that window into the work that you've done. And I think this is really a good educational opportunity for a lot of the researchers in the audience who really, like I said, want their work to be relevant. And so I think understanding how decisions are made within government at your level is really useful to us. So we only have a few minutes left. I want to invite, if folks from the audience have very pressing questions, I apologize, Professor Saruma, but if people have pressing questions that they'd like me to ask, please put them in the chat now. And then I'll ask a final question, which is, we talked about the collaborations that SIGA and NERA researchers have with PMDU. In this case, they're related to public health. And I really hope that those studies will be useful to you and your team as you make decisions about boosting health worker attendance. I think there's another project related to mask use, in the context of COVID. SIGA is also collaborating with Makerre's Departments of Statistics and Public Health on a new lab called the Impact Evaluation for Evidence and Decisions Lab. And I want to ask, what advice do you give to our colleagues who are running the Impact Evaluation Lab at Makerre and to other researchers in the room if they're going to make their work and their careers most useful for policymakers?
I think they are going to get a shock. I have so much work waiting for them.
Oh, good. Okay.
I'm going to talk to the Vice Chancellor and ask them to come, and then we have a chat. We have a huge new project that involves the whole country.
Mm.
And we need all the help we can get.
Mm-hmm.
Oh, we need to collect data from over 10,000 parishes and over 8 million households. So the amount of work we have is huge. I had already talked to Makerere about it, but mainly to the data processing section, the computer science section. We'll be happy to include the statistics department. We, as government, of course, we collaborate mainly with the Bureau of Statistics, but we are happy to, I know that the Bureau of Statistics has a close relationship with the Department of Statistics in Makerere. So we do have ample opportunity for collaboration, and I think can be very exciting for you.
I see we just in the last minute here have a very interesting follow-up question from Norma Altschuler, who's at the Hewlett Foundation. In addition to providing advice for researchers, can you also provide some advice for funders, for the partners who are supporting this work? What would you like to see funders do differently?
I don't know. My experience has been mainly with the World Bank and DFID. They have supported us a great deal, and they've done so by understanding us, understanding the problems we have, and of course being in communication with us. It is obvious that if we are not communicating, we don't have an opportunity to talk to each other. We cannot know what each other's interests. So where there is an opportunity to communicate, and I'm not sure how that can best be done. But usually most departments that I know, ministries, definitely do not have all the funding that they need. And so once there's an opportunity for funding, will tend to be positive, we tend to be receptive to communicating, see how we can mutually agree. So if the funding conditionalities, sometimes the conditionalities are not acceptable to government, but hopefully if the intent of the funder is not hostile to government policy and government interests, I think there will be no problem in reaching agreement on working together.
Mhm. Well, Professor Saruma Ezra, I am so grateful that you have taken the time to share some of your experience with us. I think this has been very interesting for me and for everyone here. It looks like now some of our audience members are chiming in the chat with some questions for you. So if you want to, and if you have a few more minutes, maybe you could read those questions and respond, but no pressure. And I'm going to wrap up now so that we can move to a break. But again, thank you. It's been a real pleasure, and hopefully we can be in close touch about all that work that you have for us.
Thank you so much, Carson. I'm very grateful for your invitation.
Thank you. And I hope you'll stay for some of the presentations.
I'll try.
Okay, great. Thanks.
Thank you, everyone, and welcome back. We are now going to have very exciting presentations. As you can see, how deep is the COVID-19 recession? And we are going to have evidence from Kenya and beyond. And this will be presented by none other but Ted Miguel, who is a professor of economics at UC Berkeley and SIGA faculty co-director. This will again then be followed by a short policy discussion with Paul Otung, who is an economics advisor at the Foreign, Commonwealth and Development Office, Kenya. We'll then have 10 minutes of moderated questions and answers for both the speakers at the end. Please feel free to put your questions on chat, comments on chat, so that we engage Ted and Paul accordingly to learn more on this topic. So Ted, welcome.
Thank you so much. It's such a pleasure to take part in this event. Can you guys see my screen okay and see the slides? Yeah? Okay, great. All right, great, thank you. And thanks, Amos, for the introduction. It was really a delight to hear Professor Saruma's perspective on issues of research and policy interaction. And this conversation will kind of move in the same direction of policy relevant research. I'm also delighted that Paul Otung will be discussing the work. I've actually interacted with him last year during the start of the crisis, sharing some of these data. And it was really a pleasure to hear his perspective then, and I look forward to it again. So I'll be speaking on some research and data related to the COVID recession. This is a project that is joint with many colleagues and co-authors, some at Berkeley, some of whom I've listed here, and many based in East Africa at the Busara Center, at Remit Kenya, at IPA, and then beyond with co-authors really around the world, as you'll see soon. So really a collaborative research project and a global project. So really great to be able to share it with this group today. I think as everybody knows, the pandemic has affected us in so many ways, affected our societies, the economy, and has clearly had major consequences for countries around the world. However, there's been many issues of lack of data and measurement to really allow us to quantify these effects. And this has been particularly severe in low and middle income countries where issues of measurement are challenging, where there's a large informal sector, a large subsistence agricultural sector, and where statistical agencies in the early months of the pandemic were often really overwhelmed and unable to keep collecting data. So even though we know there have been impacts, really understanding the nature of those effects has been more challenging than we would have liked. I'm going to focus for most of this talk on East Africa, although I'll bring in some evidence from other settings. East Africa is a natural setting to focus on for this group. Of course, the East Network and NIERA have a strong focus on East Africa. It's also a region of the world where a large share of the population is living on only a few dollars per day. So poverty and food insecurity are major issues. And at the same time, at the start of the pandemic, there was a lot of uncertainty about how the crisis would affect East Africa and other low and middle income regions. Much of the population is young and so potentially at lower risk of infection from COVID. And there's also the possibility that during the crisis, subsistence agriculture could provide a kind of safety net for many households. So understanding the data is very important because we are unsure of how things would evolve. So let me focus today just in this brief talk on 3 pieces of data, and I'm going to present them in turn. The first piece of data is data from phone surveys collected in Kenya that attempt to measure the impacts of the COVID crisis on households and firms. This is data that was collected among a representative sample of households and firms in Siaya County, so in Nyanza in Western Kenya. And it's part of a longer standing project, a randomized control trial that provided large scale cash transfers to households in that region starting about 5 or 6 years ago. So we were already working in this county, had a sampling frame, had a population of households we had been surveying, and we switched the data collection to phone surveys during COVID in order to gather data during the crisis. We were very lucky that, again, we were set up in the field. We were able to start data collection in early April. So really right when the crisis was hitting, just a few weeks after lockdowns. And we continued that data collection for several months through the end of August. This population has high rates of phone ownership, and we got a high overall response rate, close to 80%. I'm going to start by focusing on the data from the first few months, but I'll tell you about some of the data through August as well. And you know, the big question that's animating this discussion is how much did economic activity in this rural region in Western Kenya fall during the initial COVID period, in the initial few months. And this is, you know, obviously very important for policymakers and for all of us trying to understand the global economic impact of the crisis. You know, as I mentioned before, measuring living standards is challenging in low-income settings because of informal employment, but there are methods that have been developed by statisticians, statistical agencies, economists, the World Bank, that allow us to address these concerns and measure income with some confidence. And especially in a setting where official statistics may not be as reliable during the crisis, this kind of data could be very important. And again, we collected this information by phone on, you know, employment, household consumption, firm revenue, both in the agricultural and non-agricultural sector to paint this picture. Okay, so what do we find? Let me give you the results from this first piece that I'll tell you about, and then I'll spend a few minutes on piece 2 and piece 3. How deep was the recession in the first few months of the COVID period? We collected data from firms, again, agricultural and non-agricultural firms, on their revenue and their profits, and we found very steep drops in both, around 40 to 50% drops in revenue and profit for these this representative sample of firms in the first few months of the crisis. So really a massive reduction in firm activity. This wasn't a typical recession with a 5 or 10% reduction. This was huge. Okay, so firm revenue was hit. We also measured household earnings and household consumption during that same period from late March. So we started the data collection in the beginning of April, but we asked about the previous few weeks. So we're able to capture data right at the start of the crisis. Earnings and consumption in this kind of March, April, May, June period fell by about a quarter. Very large reductions in earnings and household consumption. So by consumption, we mean expenditures, what they're buying, what they're, you know, spending their money on. Again, a huge negative reduction. And these are the average drops across all households, meaning some households were experiencing even larger reductions in income and consumption. We also measured food insecurity, both among adults and children during this same period. And there were large increases of between 20 to 50% in food insecurity, rising especially in the early period, and then starting to sort of stabilize later on. And I'll discuss this more in a minute with some signs of recovery. One thing that I do want to say is all of this data from the beginning, from when we were collecting it last year, has been posted on a publicly available website called kenyacovidtracker.org. You can see the link here at the bottom. We've shared it with links in the Kenyan government, with donors, with other partners, with other researchers, so that it could be publicly available and usable. So if you're interested in these patterns and many, many more collected in the survey, please check out Kenya COVID Tracker. Not only is the data there for this region of Western Kenya, but also the data from nationally representative surveys that members of our team carried out in collaboration with the Kenya Bureau of Statistics and the World Bank are also posted there. So it really is a unique resource for people interested in these questions: policymakers, researchers, members of the public, media. So big recession immediately in these first few months of COVID. Well, what happened later on? As I mentioned, we collected data through end of August, and now these are just figures directly pulled from the Kenyan COVID tracker. What you can see is there was recovery in July and August. So once you get out to those weeks 16, 18, 20, now we're into July and August, and this is a measure of labor supply, hours worked. You can start seeing an increase in labor supply in July and August, pretty stark, both in agriculture and in wage labor. And if we look at food security, now these measures are measures of meals missed. So these are the days that people skipped meals. You can see that those days on average were very high in the first 12 weeks or so of the crisis, but by the end of the crisis, they fall a lot back to sort of more normal levels. So it really does look like with easing of lockdowns and changes in policy by July and August, there really was the beginnings of a recovery in Kenya. All right, so that was the first bit of evidence. The second piece of evidence I want to show you quickly is evidence from this sample, this RCT, randomized controlled trial sample. Some of the households in the sample 4 or 5 years earlier had received a large cash grant from the NGO Give Directly. This was a grant that was equivalent to about 75% of annual household income, so a large amount of assistance. And the question we ask is, does having received this large amount of assistance several years earlier help shield you from the worst effects of the crisis during COVID? And you might say, well, why would that be the case? They got the money earlier. Well, there's several reasons why. One is a lot of the households that receive this cash grant, we know from our earlier study, the Egger et al. 2019, they accumulated assets and savings and household durable assets and durable goods that could help you in a crisis, because those are things that could be sold to give you money. So there could be dissaving of assets that could help shield recipients. What I'm going to show you here is the simple difference between those who received the cash earlier and those who didn't, so treatment versus control. And these cash grants were targeted to the poorest households in the sample. So the question is, if you give assistance to the poor, does it have persistent benefits from them and help them deal with a crisis later on? So again, these are the results, kind of a similar setup to what I showed you before. On the horizontal axis, we have the timeline from late March through the end of June, that same time period before. And on the left here, we're showing you effects on earnings, so household income and earnings at the top, and then at the bottom, household consumption. The solid line is the treatment group, the dashed line is the control group. And then we've shown you the average effects here. So on average, earnings and consumption are maybe 2 or 3% higher 5 years later in the treatment group, those who had received the cash earlier. But neither of these effects is statistically significant. They're not very strong effects, but they go in this direction of higher earnings and consumption. We see more striking effects when we look at food security. So what we have here is missing meals, where here higher values means more missing meals. That's worse. And what we see here is a negative effect on missing meals in the treatment group, meaning those who got cash 4 or 5 years earlier are missing fewer meals, especially in those first couple months of the crisis. You can see the solid line is sort of below the dashed line for most of those first couple of months. So what's going on? In our data, we find that these treatment households are dissaving more. They're selling off assets. They're basically using their savings and their assets, and that's allowing them to consume more food and miss fewer meals in those first couple months of the crisis. So, even 4 or 5 years later, we're finding some benefits to having received cash assistance earlier on in guarding the food security of these households. So that's an interesting finding. Okay, that was the second set of results. Now let me show you the third set of results. The third set of results is from a paper that was recently published a couple months ago in the journal Science Advances. It's Egger et al. There are many collaborators. I think there are 30 co-authors. It was a very exciting collaboration between research teams based in California, based in East Africa, based in Europe, some from Asia, where we got together, assembled data from 16 different surveys across 9 low and middle income countries, all of whom were collecting this kind of phone data that I've just been mentioning during the COVID crisis to say, can we characterize in a more global way what is going on with low and middle income populations around the world during the crisis? There are some differences in the measurement, but some common measures of income, employment, and food security. And that's what I'll focus on here, again, during those first few months of the crisis. So this was really a unique research collaboration and very exciting. There are multiple African samples here, as you can see. There's Burkina Faso, Ghana, Kenya, Rwanda, Sierra Leone, and then multiple samples from Asia and one from Latin America, Colombia. What do we find? I'm not going to be able to show you all the data from all these surveys, but what we find is in all 16 of the settings, there are increases in the proportion of people claiming they'd experienced a drop in income. And there's variation across the different settings, different populations, but the median share is 70%. So what does the 70% mean? It means 70% of the household respondents say that during the crisis, their income and earnings fell. That doesn't mean that income fell by 70% on average. It means 70% of households experienced a drop in income. As I showed you from the Kenyan data, the average drop where we can measure it is more like a quarter of income, which is still a huge effect. But this is saying the vast majority of people being surveyed experienced a negative economic period during the early COVID crisis. And this is just a little bit more data. The top left here is really just reproducing the figure on food insecurity that I showed you before in the first few months of the crisis. The top right is the same data collected in Sierra Leone, so a West African setting. And what you can see is kind of a very similar pattern and also very large magnitudes in terms of the proportion of adults and children reducing what they eat during the crisis. And in fact, quite striking numbers in Sierra Leone, increases of 75 to 98% in missing meals. The bottom panel here is some data we collected in the Kenyan sample on domestic violence. These were asked when possible, ensuring that the respondents over the phone could speak freely and privately about their experience. This is domestic violence experienced typically by female partners and also by children, where parents were asked to report on whether children had been beaten, et cetera. And what you can see is in the early parts of the crisis, especially the first couple of months, there are some increases in domestic violence. They start, especially the adult one, starts to reduce eventually, maybe as the crisis eases a bit. But on average, there was something of an increase in domestic violence, not statistically significant, but a suggestion that this was another dimension of another potential adverse consequence of the crisis. All right, there's a bunch of research issues that I'll just briefly mention, and I'm very happy to take these on in the Q&A. It's very important to understand seasonality, or some of the patterns we're measuring, just patterns really more related to the agricultural cycle rather than COVID. Well, in several of the samples, we actually had data from earlier years during this same few months. And we find that 2020 during these same few months looks much worse in terms of living standards than those earlier years. So it doesn't appear to be purely a seasonality effect. Plus the magnitudes of the effects that we document are just much larger than the seasonal variation we would expect. There's also questions of population representativeness. As I mentioned, there are 16 different samples in this study from different countries. Some of them surveyed samples by using what's called random digit dialing. They just called phone numbers randomly and saw who answered. And the people who have cell phones may be different than others. They may be richer, et cetera. We have some evidence of that. But there are also some samples in the analysis based on earlier studies like our CIA population, which are meant to be representative of the population, rich and poor, whether they're rural, have a phone, et cetera. We're hoping to capture them. Now, of course, the data collection during this period relies on people having access to a phone to answer the survey. So again, we may not have full representativeness. But one of the things that makes us feel confident that the broad patterns are robust is just how common the effects are across countries, across samples. We were able to split our sample into those who are richer and poorer, high SES, low SES, socioeconomic status, and we get the same sorts of patterns, big increases in food insecurity, big drops in income, really across the board. So, the best sense is this recession around COVID in those first 3, 4, 5 months was just really unprecedented in its global scale relative to any global economic crisis we've seen in decades. That's the bottom line of this analysis. Okay, so let me just wrap up and then turn it over to Paul for his comments. What policy responses should we think about? Again, in the data, I didn't emphasize this in the last few minutes, but we also have data on the share of households that were receiving assistance from social programs. And on average in the countries in our sample, very few households were receiving official government or NGO assistance in those early months. Now that situation has improved somewhat over the last 6 months or so as government assistance has expanded, as there's been some expansion of foreign donor assistance. But our best sense is these responses are still inadequate for most households. So there really is a need to ramp up that assistance. The exact design of that assistance is something that's going to depend on the setting. But again, given how broad-based the economic shock is, it's going to be important to think of large-scale, broadly targeted assistance. And this problem isn't going away. As we've seen, there are new infection waves in many countries. In Kenya, in the last couple of weeks, there's been a lockdown again. Nairobi and the 5 counties around it are locked down. People can't travel around the country anymore, just like in those early days last year. So, we face the risk of wave after wave of these infections until there is mass vaccination. And I think all that we can really do is try to encourage, I very strongly believe this personally, encourage the rich countries that are really hoarding the vaccines right now to share them more broadly with people in low and middle income countries, with African countries, and not just keep them for ourselves in the rich countries. It's really critical for all of humanity that we do this, and for the whole globe to get out of this economic and health crisis. We won't get out of it until we're generous and share the vaccine so we can all move forward. And then just a last word, as I showed you, there was some indication that economic conditions have rebounded. Again, for how long, we don't know because of these new lockdowns. But even though there's been some recovery, it's been quite uneven. There are major sectors in many countries, including East African countries, for instance, tourism, that haven't recovered, transportation that haven't recovered. These may account for large shares of GDP in countries like Kenya and Tanzania that rely on global tourism. And so this is something that's going to stay with us until we achieve global vaccine coverage. So I just want to leave it there. I think I'm at my 20 minutes. And I'm really delighted to hear about Paul's responses and also the broader conversation. Thank you very much.
Thank you. We'll now go to Paul. Paul O'Toole, please pick up. Tell us.
Yes, thank you very much to Ted, and I also want to thank Chelsea and the team for the rich coordination around this work. It's not one of the easiest trying to coordinate an event of this magnitude across the globe. And I want to say the presentation by Ted is rich and not very easy to comment on because of the robustness of the results. So you really need to think through the box. Now, to start, I find that the paper is very timely and informative, especially in a times of a crisis where the need for information and data is of essence to both the citizens and, of course, the authorities to make sure that their decisions are well informed. When the first case of COVID was reported in Kenya, that is around March, there were legitimate concerns about the possible health impact, but it was very quickly realized that over and above the health impact, this was morphing into concerns about livelihoods. Basically, the demand and supply side of the economy were affected, broad-based impact of it. And therefore, these call for balance between livelihoods and liberty and lives. Liberty in the sense that some of the measures actually restricted movement across, as Ted's presentation indicated, access to markets being restricted, but also new laws to implement some of the restrictions in place. And I must say the paper introduces very well the impact of COVID in Kenya, and much more aligned with what we are observing, both from the government itself, that is Kenya National Bureau of Statistics, and also the World Bank. And I must say the paper is also rich because it has brought the microeconomic impact of the pandemic, which could easily get lost in the big picture. Most of them, the headline news is growth has dropped by negative 0.6. So I must say this is good. It brings back the discussion to the micro. In terms of impact, yes, you captured it very well because the World Bank reports that around 2 million people may have lost jobs, and the figure could have gone slightly higher. This potentially reverses the gains in reducing poverty levels in the Kenya. Kenya had made some very good progress in poverty reduction, but then the pandemic seems to be reversing the poverty rates. The government did respond, and there's a general feeling that both the fiscal and monetary policies that were implemented by the government were timely. The speed of response was timely, and the general effect of the policies have been felt. More specifically, the monetary policy that was implemented by the Central Bank of Kenya, trying to waiver payment on loans, waivering transfers between mobile money and bank accounts. This actually improved the financial deepening and utilization in the country. In terms of the data and the presentation of it, I must say the paper addresses well the data collection, analysis, and goes further to highlight some of the limitations that will come due to phone surveys. I find this important because some of my comments that follow actually try to narrow down into some of the limitations that phone surveys. There are so many questions that you can ask over telephone call. But then the paper also makes very good work to bring out the metrics that would allow comparability, especially when you are talking of different countries in the world. In terms of findings, I find the findings are well reported and captures what are the surveys, as I indicated, what are the surveys are finding in Kenya. So it is very much a true reflection of the state in Kenya, as you say, what is happening on the ground. Distinction between rural areas is very clear, even though I would have wished to see some comparative figures on what has happened in the urban areas, simply because one, there was a general feeling that the impact of the pandemic could be much more in the urban centers, of course, by virtue of where urban residents work. Rural areas could be covered by agriculture, and you did hint into that when addressing seasonality around the result. The steep increase in labor supply and of course a reduction in food insecurity could be more of the seasonality, cultivation, harvesting time, matching the time you are doing the survey, even though you rightly pointed the impact of the pandemic seems to far outweigh the seasonality in terms of agricultural activities. A comparison with the urban centers would really make it very rich. Now, another thing that I would also wish to highlight in the paper You noted this in the introduction part of it about poverty levels, but then it would also be useful to understand the inequality, both in terms of health and also in terms of income inequality. As it were, the rural areas, naturally, the perception in rural areas is that majority of them are living below the poverty line or very close, and therefore pandemic of this nature would drastically increase the number that falls into below the poverty line. A comparison of that, trying to bring in the levels of inequality, and you also highlighted some are deceiving. So what is the extent of inequality that this pandemic may have generated? There's also a report, a number on access to health services, but then it would also be useful to bring in the aspect of the quality of those services. Remember, access, yes, but the quality may have reduced given that one, doctors for a while have been having issues with their employers, and therefore some have been on go slow, going to work, yes, but not really delivering. That would be useful. And of course, medicine, access to medicine would also be a useful component to it. You go to the hospital, but as it were, the cost sharing arrangement at times makes access to medicine difficult in the context where incomes are dropping and jobs are being lost. And of course, that would also be useful given that COVID seems to have a very strong correlation with underlying diseases, and therefore addressing some of the underlying diseases through access to good medicine would be useful. Now, and I've highlighted this point, even though I'll want to emphasize in it. The coping mechanisms, especially in the rural areas, it would be useful to understand whether the coping mechanisms also had a component on migration. For example, in rural areas, at times people basically send their kids to families that they feel are richer. I was wondering whether you were able to pick that. And of course, also a movement from urban to rural areas, especially those who are really, really impacted by this pandemic. It would be useful to understand that dynamic in movement. Now, the pandemic also has also revealed the vulnerabilities of the rural households, and of course, subsequently, their sources of livelihoods that a shock of this magnitude would definitely drive a number of them below the poverty line. I highlighted that point earlier. You may want to bring in that. There's also need, as you notice, some of my comments are based on the limitations that there are only so many questions you can ask, but then they are very useful questions if you want to engage the policymakers. For example, the timeliness of the response, which at the national level, the general perception is that the response was more time, but then do you see that in the rural areas? Do the rural folk feel that the government responded appropriately and with the right tools? You just highlighted that cash transfers may have improved, but initially, a majority of them, when the pandemic started, majority of them fell left out of these cash transfers, meaning there was a delay in terms of including them. So you want to bring out that component. There's also another important aspect that would be useful to bring out, especially the private transfers. There is the Central Bank of Kenya is reporting that diaspora remittances may have actually increased during over the 1 year period. It would be good to get a sense that where are these transfers going, especially if are the rural folks getting transfers from abroad or from the cities or the urban centers. That would be a useful policy discourse with the government. Then important to note that market conditions and how the supply shock impacted on jobs, but it would also be useful to understand how these conditions could result into the spread of COVID, especially knowing that in rural areas, enforcing some of the measures could be difficult. Keeping distance, for example, wearing mask consistency would also be difficult. So it would be useful to understand whether the conditions in the markets may be one also the cause of increase in this pandemic. And finally, in terms of the policy advice to ministries of health and finance, and of course, linking that to the policy recommendations in your paper. The big question is, which households will be mostly affected by this? It would be useful to bring that component, the unskilled, poor segments, less education, less assets, which only seems to be having labor as their source of livelihood, seems to have been much affected. That would be a very useful policy discussion. And it's also good to note that you talked about expanding the social safety net. Yes, expanding the social safety net is important, but then you realize that the traditional way of framing social safety net in Kenya, the old age, for example, may have left some people who traditionally are not captured, but are really right now suffering. And therefore, targeting around the social safety net programs is important. Informality. In the introduction, there was a mention of high informality, but it is one of those sectors that we can't ignore. It plays a critical role in terms of job creation, and therefore some policy suggestion around modernizing the informal sector going forward, at least to support the recovery, the impact on occupational choices, and what does it mean for growth models going forward in a post-COVID world. Could this be used for some a form of structural transformation in the rural areas, given the trajectory and the role of ICT? Silver lining of this pandemic is the financial inclusion, greater use of M-Pesa or mobile wallets, so to speak, in Kenya. Can that be built on to make sure financial inclusion and utilization is framed appropriately? And then how best should the government employ access and use of information to trigger behavior change in the context of policing? Some of the measures are very difficult. Can the mobile phones be used to nudge behavior change? And of course, a call for further research, a bit on trying to look at the link among the value chains between rural and urban centers, and of course, a vulnerability map within the economy to identify which sectors of the economy are susceptible to this kind of economy-wide shocks. And I want to believe of the technology, better modeling of the economy, machine learning, and opportunities going forward. Thank you very much.
Thank you, Paul. That's a very exciting review of the discussion, and it's very passionate. We only have about 3 minutes to end this session, so I will request that we put questions on chat, but in the meantime, we allow the little time remaining for Ted to possibly respond very briefly to Paul's remarks. I will also put a few other questions on chat for everyone. Thank you.
Thank you so much. And I've seen a lot of really great questions on the chat coming in. First of all, let me thank Paul, Dr. Otung, for his comments. They're very thoughtful, and he really touched on a lot of important issues, only some of which we could study in this paper. Let me just mention one or two of them very briefly, and then I'll go to the chat as well. I really enjoyed the discussion, and these points on migration I thought were really fascinating. People are coping with the shock in many different ways, potentially not just dissaving, but also migrating, having children migrate. And in the early sort of months of data that I mainly focused on, we didn't have as much information on that. We are still collecting this data, both phone surveys and now in some cases even in person with social distancing, all approved. But as things have opened up, we've managed to expand the data collection, and there's very detailed data we're collecting on migration. And one thing I'll tell you from the initial look at the data is from last year to this year, there's been a much higher rate of migration of households out of Siaya County and into Siaya County, general movement, than in a typical year. So we still have to do that analysis and quantify it, but it's certainly the case that we're seeing more of this movement And I think the crisis almost certainly has to be the reason why. So I think you put your finger on something important, and then we're very, happy to, do more analysis on this. We're also collecting data on private transfers. So you again raised a point that now in our data we've expanded. So we don't have, a strong data on that yet, but we're collecting it, and we hope to say more about the nature of transfer. So I think between migration and transfers, we're seeing the wide range of responses that households are taking, and hopefully in the next version, we can say more. I see, lots of very good comments. Amos with a comment, what do we need? What evidence do we need to reopen the country? I see just before that in the chat, Norma has a comment about like what type of data or information do we need, should be funded. I would say right now we're in a phase where it would be a shame if just because some of the richer countries are achieving max vaccination and feeling like, oh, we're coming out of this crisis, if donors and policymakers stopped collecting detailed data of this kind in low and middle income countries, because this could drag out. And I would say like that would be a mistake. So I think, continued, household data collection, health monitoring is going to be very important. And one of the things that's been very exciting about this process is just how interdisciplinary the data collection has been. And so some members of the SIGA research team are collaborating with colleagues in East Africa to study mask wearing and mask use, which again, Dr. Otung referred to, and that's a collaboration between health scholars, economists. So I really do feel that given how complex the issue is, these interdisciplinary teams need to be able to continue collecting panel data to document what's going on. The crisis, unfortunately, is far from over, as we've seen from the lockdown. So I'll just leave it there. And again, thank Dr. Otung for the really thoughtful comments. And also I did try to respond in the chat to several of the comments, but I'm happy to follow up after the talk as well.
Thank you very much. Our time is up. Unfortunately, we will not take questions from the audience directly, but kindly put the questions on chat. I'm also putting the questions that I got directly from the audience on chat, so that we can continue this conversation. We will now move to the next presentation, that is on task shifting treatment for HIV infected adults in Uganda, the SHARE trial. And to take us through this, we have one of the East Fellows, NIARA Fellows, Jane Tusime, who is Associate Professor of Epidemiology, and she founded the Department of Public Health at Bustema University and Soroti University in Uganda. Jane is currently working at the World Health Organization Africa Regional Office in the Public Health Emergencies Program. A short policy discussion with Patrick Okello, who is the commissioner at the Ministry of Health in Uganda. Jane, over to you. Jane, you are on mute.
Okay, so good evening, everybody. For the next 20 minutes, I'll be discussing the results of the trial that we did a couple of years ago. It has been running and was just published on 1st of March. So it's still very fresh in the journal. So the SHARE trial, the acronym SHARE stands for Sharing HIV/AIDS Responsibilities and Efforts. And oh, sorry. Wow. My slides are not moving. Sorry, my slides can't move. Almost my slides not moving.
Jane, maybe try unsharing and then sharing again.
I'll just give you a little background to this study. Now, as you may know, more than 2/3 of the global population of people living with HIV/AIDS reside in sub-Saharan Africa. And in addition to that, sub-Saharan Africa has the lowest rates of physicians per capita. Actually, in Uganda, we have, with a population of about 45 million people, we have less than 2 medical doctors per 10,000 people. So really showing you the shortage of doctors and health workers generally in the country. Now, the joint United Nations program on HIV/AIDS embarked on a strategy to end the AIDS pandemic by 2030 by setting up targets that 90% of people who know their HIV status should be initiated on antiretroviral therapy, and actually increase that to 95% by 2030. And WHO also recommends that all people living with HIV need to be initiated on antiretroviral therapy under what they called the treat all recommendation. Now, Uganda as a country is a low-income country with a generalized HIV pandemic and a high prevalence of HIV, which is about 6.2%. And Uganda went ahead to adopt the treat all recommendation from WHO. And WHO has also recommended task shifting as a means of increasing access to HIV/AIDS care services amidst workforce shortages in the country. And when we talk about task shifting, we mean moving specific tasks from highly skilled persons to lower health cadres by giving them some more training and then supervising them to make sure that they do it. So it was against this background that we decided to do this study, because in Uganda, we have many more nurses than physicians. So we wanted to see whether nurses could initiate and monitor HIV patients as well as doctors do. And the outcomes of the patients were not inferior to those of the doctors. So that was the background of the study. So this was a parallel unblinded randomized controlled trial using a non-inferiority design to test if nurse-initiated and monitored antiretroviral therapy is non-inferior to clinician-initiated and monitored antiretroviral therapy for clinically stable HIV-infected adults in Uganda. And our study population were HIV-infected, ART naive. When we say ART naive, we mean those who have never started on antiretroviral therapy, and clinically stable adults who are eligible for antiretroviral therapy according to the Ministry of Health National HIV Treatment Guidelines. And the study was conducted at HIV treatment clinics at 8 of the 12 public regional referral hospitals in Uganda. So the sample size for this trial was 1,760 individuals with 878 individuals per arm. And this sample size calculation was based on showing non-inferiority for a composite endpoint of treatment limiting events. So the events of interest in this study were 4. That is an all-cause mortality, virological failure, toxicity due to the drugs, and loss to follow-up after 12 months. And a composite endpoint was a participant having any one of those 4. Somebody could have all the 4 endpoints or more, or 3 or 2, but as long as you had at least one, that was our composite endpoint. So our calculation for sample size was based on that. And it was also, we also used a non-inferiority margin of 6%. Now that margin of 6% was based on a similar study that was done in South Africa, where they are comparing again nurse care to doctor care of HIV patients. And so we assumed that the failure rate of patients under clinician care would be 24%. And that for nurses would be slightly higher at 30%, thus giving us an inferiority margin of 6%. And our hypothesis for the study was that the nurse arm was inferior to the clinician arm, and that's we sought to reject this null hypothesis. And to account for clustering effects, because the study was being done at several sites around the country, we considered a design effect of 1.25 and adjusted for an attrition rate of 12%, hence ending up with a sample size of 1,760 people. Now, for randomization, we used simple randomization to allocate participants to either the nurse arm, which was the intervention arm, or to the clinician arm, which was the control arm, with an allocation probability of 0.5, meaning that every participant had a 50% chance of being allocated to either arm. And the randomization code was generated off-site at some other central office, and assignments were sealed in opaque envelopes and then sent to the study sites. So after the participants were consented for a screening, they were asked to pick an envelope from a box that had all the different envelopes, the opaque envelopes. So the participant would pick it and then open it in front of the research team and then determine what the allocation was. Then the research team would take them to the appropriate healthcare worker, whether it was a doctor or a nurse, to determine their eligibility and study enrollment. Now, for all the participants, at baseline, we determined their viral load to know how much virus they had in their blood before they started antiretroviral therapy. And since they were ART naive, they were also initiated on antiretroviral therapy at baseline. And they also received other treatments like the cotrimoxazole, which they always use for prophylaxis. And they also received HIV counseling and adherence counseling to make sure that they adhere to their medication. And this was done to all participants in both arms. And this was following the Ministry of Health guidelines. Then each participant had monthly clinic visits that were scheduled for a period of 1 year. And at each of these visits, they underwent clinical assessment, which included measuring adherence to their medications and also refilling their medications. To monitor treatment success and safety, each participant had a couple of laboratory tests that were done at 6 and 12 months after initiating ART. And these tests included the viral load test, a complete blood count, liver function tests, renal function tests, and CD4 counts. So our primary study outcome was the composite endpoint that I've already told you about, that was examined at 6 months and 12 months post-ART initiation. When we say all-cause mortality, we mean death due to any cause during that time from the time that they initiated the therapy. So any cause of death was counted. Then virological failure was defined as having 2 successive viral load measures of 1,000 copies of virus per ml of blood at 6 or more months after they had initiated antiretroviral therapy, which were taken at least 4 weeks apart. And for toxicity failure, this was any study participant in whom treatment was discontinued or changed because of intolerance to the prescribed medication, and then lost to follow up at 12 months post-ART initiation was when participants failure to return for care for 3 consecutive scheduled monthly visits. So those were, our outcomes. So for the statistical methods, the primary endpoint analysis were based on both the intention to treat analysis and the per protocol analysis. And non-inferiority was established only if both analyses were supported. And we did a comparison of proportions of the outcomes in the intervention arm and the control arm. And statistical inferiority was concluded with upper bound of 97.5 confidence interval limits of the difference in the proportion of the composite outcome between the two study arms, if it was less than or equal to 6%, margin of 6%. We also conducted incidence and time to event analysis, and we compared the two groups using Kaplan-Meier curves and the log-rank test. So these were our findings. I'll quickly take you through the participant flow. Now, we consented 1,974 participants. They were consented and randomized, and we ended up with 992 in the clinician arm and 982 in the nurse arm, using our 0.5 probability of allocation. Now, from those ones, we had some excluded due to several reasons. As you can see, there were some who were ineligible, some who did not return. So we ended up enrolling 1,760. And of those, 885 were in the clinician arm, 875 were on the nurse arm. But then we went ahead to exclude some because of some randomization error that was done. So for the intention to treat analysis in the physician arm, we had 844 participants and 841 in the nurse arm. Then again, some were excluded because they migrated out of the study area. Some were not compliant to the protocol, and some had withdrawn consent. So for the protocol analysis, we had 815 in the clinician arm and 803 in the nurse arm. So these are the baseline characteristics. So at baseline, we collected several social demographic characteristics and clinical characteristics to compare the two arms. And basically, without going into the details, if you just look at some of the figures here, you realize that the two groups are very comparable. Just look at age, for example. In the clinician arm, we have a mean age of 34.9 and the nurse arm is 35.3. Just look at education. Those who did not have education were 67, 67. If you look at, for example, WHO staging, stage 1 and 2, we had 845 in the clinician, 841. So basically, when you look at all the parameters, they seem to be comparable, which points to the fact that our randomization was successful and we're able to control for confounding in this study. Now, this is a very important table that actually helps us to respond to answer our question, to test a hypothesis. In here, we look at the risk of acquiring these endpoints in each of the arms, and then the risk difference, because we're going to use the risk difference to determine whether the nurse arm was inferior to the clinician arm. So again, when you look at these figures for both the individual outcomes and the composite outcomes for both the intent to treat and the protocol, when you look at the risk difference, which is the last column, you notice that the difference is less than 6%. Remember, our guide was that the risk difference had to be 6% or less in order for us to say that the nurses were non-inferior. So here we see a risk difference, which is less than 6% for all the parameters that we measured, clearly rejecting the null hypothesis that says that nurses are inferior to clinicians in initiating and monitoring HIV patients on antiretroviral therapy. Further on, if you look at this forest plot, it also shows that all the confidence intervals for all the measures were not statistically significant, because as you see, they are all crossing this line of no difference, zero, showing that they were not statistically significant. And again, None of them ever went past the 6% margin. Again, further confirming or rejecting the null hypothesis of inferiority of the nurses. So we also did survival analysis looking at time to the first event in both groups. And again, the curves here clearly show that there was no significant difference between the two groups. The time to first event in the clinician arm was 9 days, and in the nurse arm it was 14 days. But as you see, according to the log-rank test, these are not statistically significant. So in conclusion, we say that this study shows that nurses were not inferior in initiating and monitoring ART in HIV-infected stable adults in a low-income country. And task shifting to trained nurses is a viable means to increase access to ART. These findings should be used by the Ministry of Health to develop a formal task shifting policy in support of nurse-initiated and monitored antiretroviral therapy to meet the demand of HIV treatment services in the context of urgent shortages of clinicians and the need for mentoring non-clinical staff. I must say at the moment we don't have a policy on task shifting in Uganda, and I'm glad we have the Commission of Human Resource here to discuss this paper. We don't have a policy towards that, but these findings should help us to develop that policy. And there's also need for countries to implement a task sharing policy to ensure collaboration among health workers in the care of HIV/AIDS patients. So as I mentioned at the beginning, this paper was published just a month ago on the 1st of March, and anybody who wants to know more about it or get the details can look it up from the Journal of AIDS, JAIDS. Thank you.
Thank you, Jane. We now have Patrick to pick up exactly from there. What are the policy implications of this good paper?
Thank you very much. I want to commend Jane for that presentation. Indeed, this study is a fair illustration of the Uganda context. But nonetheless, I want to state that Sub-Saharan Africa, as Jane stated, is faced with a severe human resource for health crisis, despite having an overwhelming disease burden. What is quite true and what has been proven is that the shortage of physicians is an especially pronounced constraint, which is compounded by labor market dynamics that render many public facilities unable to attract and retain physicians. In the circumstances, therefore, because the physicians cannot be attracted, they cannot be engaged, most health facilities have opted for alternative B, which is engagement of nurses to cover gaps that would have been covered by physicians. It is true that countries in Sub-Saharan Africa have grown to increasingly rely on nurses or other non-physician cadres, especially those with shorter tertiary training cycles or those who are less specialized. And indeed, in this study, of course, I know that it was limited to a comparison between clinicians and nurses, but it would have been better if it was expanded to include the roles of other key stakeholders in service delivery in the treatment of HIV/AIDS patients, including the laboratory technologists, the radiologists, and other support staff. I agree that in Uganda, nurses constitute as high as 80% of the entire workforce. And as stated, the World Health Organization has released policy guidelines recommending task shifting from physicians to non-physicians, such as nurses and midwives. WHO recognizes that nurses and midwives can provide services in the clinical setting, such as HIV clinical staging and the management of opportunistic infections. But in doing this, what we should bear at the back of our minds is that the nurses may not be able to do it alone. They need support in one way or another from physicians, especially regarding very complex cases. I want to agree and to note that the expanding roles and increasing importance of the nursing workforce in health services delivery in resource-limited settings is not adequately documented. And I think this has been noted in the study. I repeat, the nursing workforce in health services delivery in resource-limited settings is not adequately documented and sufficiently recognized in the management of HIV. What for long seemed to be well documented are the traditional roles of medical doctors. The role of nurses, of course, lately has also expanded tremendously in health facilities in Uganda, especially during the era of antiretroviral therapy, the ART scale-up, that commenced about a decade ago. But prior to that, in terms of participation, I think the roles of the nurses was very limited. As stated earlier, most nurse-led HIV clinics are mainly based in rural settings. A number of health facilities have deliberately adopted nurse-led HIV care models because they are very cheap and affordable. And I think that should have come out quite clearly in the study. The nurses constitute the majority. The nurses are easier to afford, they are affordable, and the nurses are easily accessible. Training a nurse is much cheaper than training a doctor. And yet, in as far as managing HIV is concerned, they more or less offer the same services. In Uganda today, nurses have been empowered to be multi-skilled with a wide range of competencies across the HIV care continuum, right from HIV testing to mainstream clinical HIV disease management. What I wanted to say is that ART administered by nurses was indeed non-inferior compared to that which was administered by physicians. Of course, we note some cases of limited scope of training for nurses, and this has adversely affected their ability to deliver according to the required standards. Because the majority of nurses in Uganda are still certificate holders. Although I appreciate the study was mainly targeting the diploma holders and above. In my view, as I stated earlier, it would have been prudent to make a clear distinction of where the nurses should start and where they should end. We should have also clearly interrogated the benefits of having the nurses working together with the physicians. I wanted to see a situation where the nurses worked alone and the physicians worked alone. And I saw that comparative coming very clearly. But I did not see a situation where you had the mix of the two. Of course, nurses are the backbone of the ART service delivery, and a select number of facilities have devised differentiated models of task shifting from physicians to nurses, in which nurses handle patients who are stable on ART. And those who may not be stable are handled by doctors. I want to admit that we do not have a formal task shifting policy. And this study will go a long way in informing our efforts in coming up with a policy. Importance of reforming regulatory frameworks governing nursing workforce, the nursing workforce scope of practice, such as the need for developing a policy on task shifting, as Jane stated, is very important. I also want to say that this study was not explicit on the expanded roles of the nurses, which included, apart from prescribing ARTs, also the management of tuberculosis and the management of ART adherence counseling. Due to the leadership and management roles associated with leading HIV clinics, management generalist skill sets have become imperative. Nurses frequently grapple with the challenge of motivating personnel in the face of rapidly expanded workloads owing to escalating HIV client loads. They get work overload and burnouts, and at times they lose morale in doing it alone. And of course, in Uganda, there is still a tendency that a nurse without a doctor may not deliver to the required expectations. It's a traditional norm. There is need, in my view, to strengthen HIV disease management in nurse education curricula, as the likelihood of nurses engaging in clinical management of ART is high. A recent multi-country study by Ford and colleagues found that in many countries, policies currently provide for ART initiation on first-line ART by non-physician scale cadre, although the same guidelines preclude them from managing children and patients on second-line ART. I want to state in my conclusion, because I promised to be as brief as possible. I want, in my conclusion, to cite the following: that this sample study was too limited, and in my view, the scope could have been expanded to include other health facilities, like the district general hospitals. I want also to observe that the Uganda experience reveals a wide expansion in the scope of practice of nurses during the era of ART scale-up in Uganda. Nurses have taken on roles of HIV disease management that were traditionally the preserve of physicians, and today, the greater number of HIV infected persons are managed by the nurses.
Patrick, we could move towards winding up here.
I'm concluding. Some nurses have not fully appreciated task shifting, hence the need for mindset change programs, which have not yet been fully operationalized. And in my view, the best option is the hybrid approach, combining nurses, physicians, counselors, lab technologists, and other health allied professionals. The importance of reforming the regulatory frameworks governing nursing workforce scope of practice in Uganda is critical. And I want to say that the study was too stringent on eligibility, selection, and recruitment criteria. I submit. Thank you very much.
Thank you very much, and for those very good reactions. So we have 7 minutes for Jane to respond to some of these questions. So first, Jane, there is a question from Esther. She's asking if the call times were paid for to encourage people to participate.
Say that again, please.
Esther is asking if the call times were paid for to encourage people to
times?
Yes.
Call times? What do you mean by call times? Am I getting it?
Okay, maybe as you review the chat, because the question as well is on chat, we could quickly move to the next one. They are asking if the results can be generalized to the whole country. Can your results be generalized to the whole country? Is a question from Peter.
Yeah, now that's an important question. Now they may not be generalized to the whole country because the study was done at regional referral hospitals. Now, the nurses that participated in the study had to have a certain level of training. They had to be degree holders or diploma holders. Now, we know in nurses, the nurses hierarchy, they have those who are certificate holders, you know, lower level. So those ones were not part of the study. And we know that the lower level healthcare facilities like the health center 2s and 3s and are manned by nurses with lower qualifications. So because in this study, we used more trained nurses, this cannot be generalized to all nurses around the country.
Okay, thank you very much. And a very interesting one here on spillover effects, on whether you studied the spillover effects of task shifting non-HIV services.
No, we did not look at the spillover effects, unfortunately. We did not.
Yeah. Okay. Yeah. Thank you. Thank you for that. And lastly, yeah, you've answered on whether it can be generalized to the entire country, and that's fair enough. So we have a minute. Maybe we can have a quick question from the audience, if anyone in the audience has a question on this specific presentation.
If anyone wants to ask, you could raise your hand.
And as we do that, Peter had also asked if you could quickly share the link to the paper. There's someone who had, I know you showed the paper, but you could just put the link to the paper on chat for interested readers.
Okay, I'll put it.
Annette, you can go ahead. Please ask your question, Annette.
Okay, thank you so much, Jane. It's not a question, it's some of the issues that the commissioner has raised with regards to the design. I thought perhaps you could spend 1 or 2 minutes to respond. For example, when he says that perhaps it would have been good if one of the arms had a combination of the nurses and the, did you call them? Okay, maybe that takes the terms, but I thought that was an important contribution from the policymaker, and which is of course relevant to the policy. Some 1 or 2 comments about his the things that he raises would be good.
Yeah, and possibly before you make that comment, Alexi, you could make your point so that she answers the two together, and then we wrap up.
Thank you so much. I just had a follow-up to the spillover effects. I'm wondering if you could maybe comment on what the implications of task shifting may be on the broader health system. Even though you didn't measure that in your study, what do you think the implications might be for quality of care if nurses are spending a lot more time caring for HIV patients? Thank you.
So Jane, you could respond to that, and then we call it a day.
Yes, so regarding the question on the design, where the commissioner was saying that we could have had another arm that combined nurses with other non-physicians, is that so? Like nurses, radiologists, and others in comparison to the physicians? Is that so, Commissioner? Right?
Yes, sure.
Now, it would have been very hard to draw conclusions because all these non-physicians have different kinds of trainings. So combining nurses with radiologists and pharmacists or whatever would have been very difficult to make a conclusion. Maybe what we could have had is to have different arms of, pure arms of, say, radiologists and this other, cadre and that other cadre. That would have been the best. But for now, we decided to concentrate on the nurses since they were the majority in the country. But more studies could be done to look at other cadre types to see how well they could, support the care of HIV patients. Then about the implication on broader health systems. Yeah, we didn't look at that, but my guess on this is that when nurses are given extra load, and I think the commissioner talked about this, it takes up more of their time, and yet they're not remunerated for that extra work. So it may end up compromising the care for other patients, kinds of patients, if they're really going to concentrate on the HIV patients. But it's something that has to come out in the task shifting policy. If you're going to shift that responsibility to the nurses, how are you going to remunerate them to make sure that maybe they're even motivated to do it, and they also have time for others? So it is an impact that is yet to be seen and needs to be sorted out with a well-designed policy to make sure that it is well done.
Thank you very much, Jane and Patrick, for the exciting analysis. And we'll now pass over to Chelsea to take us to the next session.
Great, thank you, Amos. So now for our last session of today, we're going to have 3 lightning talks related to health, and each of the presenters are going to have 5 minutes to present, and then we'll have about 10 minutes at the end for questions for all of the presenters. So first of all, I'm excited to introduce Benjamin Chibuye, who is a PhD candidate at the University of Kiel, and he's going to be presenting his work in Zambia on financial incentives in the health setting.
Good afternoon, evening, or morning, ladies and gentlemen, depending on where you are. Hello, hope everyone can hear me now.
Yes.
Wonderful. So it's a pleasure to present to you the results of our work in progress titled "Do Financial Incentives in a Health Setting Have a Dark Side? Experimental Evidence from Zambia." So just to mention very quickly that this project is joined with my colleagues, Binush Kajavi and Peter Angoma. So to get straight into it, this is kind of our plan of action for the next couple of minutes, starting off with our motivation. So healthcare provider pay remains at the very topmost of the policy priority agenda, certainly as part of the ongoing COVID-19 pandemic, which continued coming up, but also as part of the wider development agenda, as part of the MDGs and their successor SDGs. So specifically, MDG and SDG health programs have used pay for performance to supplement healthcare provider pay in low and middle income countries. And a good example of this is the results-based financing project that has been implemented in about 29 developing countries, including Zambia, which the study is set. And this program has basically involved financial incentives being paid to providers, performance-based financial incentives, and these have been paid on only a subset of health indicators that the providers are responsible for. So interestingly, for our purposes here today, this application of this program in this way clearly violates agency theory with multitasking incentives, which basically says, in this kind of framework, agents will inadvertently focus their effort, their attention on the incentivized aspects of output and kind of like focus their attention less on the non-incentivized. So we asked ourselves how this discrepancy could potentially exist in this particular way. And potentially what we thought is maybe multitasking effects in the health sector as regards healthcare providers are somehow mitigated, and that could potentially explain this discrepancy. So for instance, there's a behavioral economics literature that basically says healthcare providers are altruistic, they're patient regarding, they have other social preferences. So the question then becomes, do they always do what's patient optimal, even when their financial incentives for them are involved? So we asked 2 very basic research questions. Can performance-based financial incentives distort the decisions of healthcare providers from what's patient optimal? And if so, can these effects be counteracted? Our experimental design was basically a health-framed field experiment with a between-subject design, 6 treatments. Our main sample was 295 medical students or future medical doctors. We did a robustness check of 2 treatments and 64 actual medical doctors. And we basically had 2 experimental tasks in the experiment: a health framed real effort task and a health resource allocation task. So participants were given some information that we collected from a rural Zambian clinic on the health resource needs of regards medications. And this was a representation of what was patient optimal. All participants were given sort of fixed show-up fee of €4 equivalent. And this was sort of meant to mimic salary-based payment. On top of that, salary-based payment in 5 treatments, we actually added a layer of performance-based financial incentivization. The decisions of the patient participants especially affect the health of real patients through a donation that we pledge to make based on the decisions of the participants. So this is a summary of the treatments. There are 4 more, but at the very heart of it, if you can understand these 2 treatments, then you can understand the whole experiment. So we had baseline treatment, which was a salary-based treatment with no financial incentive, and then an incentive treatment with an extra layer or an extra dimension of a performance-based financial incentive that went to the participants themselves. So 2 basic treatments. We added 4 more treatments on top of that, but the other 4 were basically amendments of the incentive treatments, adding in different primes and changing what was incentivized to see if we could counteract the effects in the incentive treatment. Now, we don't have time to go through all of them at this particular point. I'll quickly move on. The information that we gave the participants basically looked like this. So there are 5 medications that are consumed in this clinic, and they each account for a proportion of the total. And basically for this one drug, amoxil, which was 21%, we actually wanted to, in some treatments, put a financial incentive to the providers themselves if they allocated more. What we wanted to see is, will this incentive or the lack thereof move the participants' allocated decisions away from the 21%. So this was basically the framework that we sort of set up. Moving on very quickly to the results that we found, starting off with just the average allocations across the treatments. So starting off from left to right, in the blue there is the baseline treatment. In the kind of red is the incentive treatment. And we see when this incentive component is added, there are more allocations to this incentivized drug. So it kind of moves away from what was allocated in the no incentive treatments. In the other treatments, apart from one, we see that the effect kind of remains, even if you try to counteract it. And it only kind of like changes when you actually change what's incentivized in this particular treatment. OLS kind of regressions show the same thing. The reference category is the baseline, the salary-based payment, and there's actually more allocations to what's actually incentivized drug. Interestingly, this is, I think, the most interesting part of our findings. The levels of effort in the effort task across all the treatments were pretty much identical. So what we expected is that people will kind of, if they allocate more, counteract that effect by actually working harder, which is what the performance-based financial incentive is supposed to do. But we don't actually see that. This is for the medical doctors. The result basically replicates, and we ran 2 of the treatments, and they also allocate more than what was patient optimal. So in conclusion, what we see is that, yes, the performance-based financial incentive does distort provider decisions, and surprisingly, effort levels are no higher because of it. That was a particularly surprising sort of finding and a key conclusion for us. The mitigating effects don't actually counteract the effects, and we believe that activities that are characterized by provider discretion could be particularly prone to these kinds of distortionary effects. So this is just we selected one participant's allocation at random and sent to the clinic, and this is just the donation that we got to make. And with that, I would say thank you very much.
Thank you, Benjamin. We'll have more questions for you at the end. Now I'll hand it over to Alessandra Cassar, who is a professor of economics at the University of San Francisco and a SIGA affiliate.
Hello, everyone. So today I'm going to talk about maternal depression. Maternal depression, perinatal depression is prenatal depression, the depression before giving birth, and depression after giving birth, postnatal depression. And it is a universal find. Maybe it's a little bit too early to start creating this colored world map, just because the data is not always comparable from one country to the other, depending on the scale. But roughly, the consensus, the idea among the psychologists is that in high-income countries, it ranges antepartum between 7 to 15% and between 10 to 13 postpartum. And there is some sort of consensus that these numbers, these rates are even higher in low and middle income countries, where the range oscillates between 15 and 25% antenatally and almost 20% postnatally. And perinatal depression has really severe implications for health outcomes, both for the mother, the fetus, the infant, the children outcomes, with a fact that continues later on in the adult life of the baby whose mother suffers from perinatal depression. And we know what are some of the contributing factors, and some are genetically. We know that a history of depression increases the chance of having more depression, but some are really adversity. Financial and socioeconomic distress are the most important one. And what's relevant here for this study is the lack of social support. There are numerous studies starting from the 90s documenting that there is a strong relationship between low social support and poor maternal and offspring health, including mental health. And here we go. Given the prevalence, given that it is a universal trait everywhere around the world, some theories have been advanced by psychologists and anthropologists that depression, rather than being just a maladaptation, rather than just being a disease, could be a natural way to solve important problem, especially at the beginning. Here I'm not talking about major depressive episode. I'm talking about at the very beginning, at the onset of depression, what it is the most prevalent one. Could it be nature's way to help the mother solve important problem? So could be seen as a healthy response to adversity, extremely painful, extremely costly for everyone in the household involved, but it might serve a specific purpose. And the idea that there are important functions that it may serve for the mother. It could inform the mother that the cost of the investment in the offspring has increased. It could help in many ways. What I'm trying to address here from an empirical perspective, if there is some support to the idea that the onset of depression can be there to elicit support from those individuals that are more linked to the mother. And I cannot go in 5 minutes in detail, but I use for measuring the risk of depression the Edinburgh scale, which is widely validated in 124 countries around the world. I'm going to use the maternal social support scale, which is again a widely used instrument to measure social support, that measure how people feel, how mothers feel with respect to the support they feel from their friends, from their family. And there are 4 questions about the husbands, especially whether they feel helped by the husband and loved by the husband. And then we have a new instrument that measures for a series of characters in a woman's network: the husband, the mother, the father, the mother-in-law, the father-in-law, the sister, the cousin, the neighbor, the friend, different kind of support, instrumental support, watching the children, taking care of the mother of the baby when the mother or the baby are sick, emotional support, how often does this particular character talks to the mother, informational support in the form of guidance, and economic support, which is if the person gives money in case of need. And what do our data show? Who helps the most? Well, just starting, so in the analysis, we can do three things. First, measure who does the most help, who helps the mother. And by far, when the comparison terms is the woman mother, so the maternal grandmother, which in the literature, in the anthropological literature, is considered to be the steady helper of the mother, we see that the spouse, so the baby's father, is the one that does the most, watches the children the most, care for the mother and the babies the most, guides the most, talk the most, emotional support also the most comes from the baby's father, and provides the most economic support. Second part is what are the risk factors then for depression? Here we have as a dependent variable, we measure what correlates with depression. The problem of linking support with depression is the problem of both the lower amount of support increases the risk of depression, and high risk of depression we know that brings people to withdraw, with people to seek even less the help of the others, and sometimes people even feel rejected from the rest of the group if other people feel like they are not pulling their weight, they are not doing enough of the job. So we know that there is this double negative effect. And indeed, we do find it with a simple correlation. We do find that those that feel that they have the least amount of support, they are the ones that have higher risk of showing the symptom of depression. But once we divide it between friend support and family support, it doesn't matter for depression. What matters the most for the woman is feeling the support of the spouse. And then the third part, so we find this negative correlation, which is extraordinarily strong, even once we include food security and all this issue. But this is the novel part of this study, is trying to estimate the causal effect. But does depression does anything, even possibly mildly good, in this sea of negative health effect on the mother, on the baby, on everyone involved? And the answer is yes. Just limiting our analysis at the onset of depression, not what we have major depression. So on the horizontal axis, we have the depression index, with 0 is rescaled to be the onset of depression. And on the vertical axis, we have the amount of support. We can, at least within this interval, estimate the causal effect from depression to support. And we find that the husband does help. The spouse significantly provides more instrumental support provides more instrumental support at the onset when depression is still mild. Economic support is not significant, but instrumental support, absolutely. Nobody throws money when a person is depressed. People care by providing instrumental support, watching the children and caring for them, and providing emotional support. Who else does anything? Well, qualitatively, we see that the maternal grandmother does something, but it is not that significant. Who is very significant is the grandfather. Again, another man in the woman's network significantly helps a lot more, especially with instrumental support and emotional support. All the rest of the character, even if qualitatively seems to help a little bit, it's not much in terms of significance. So the sibling help a little bit more, the cousin, but it's barely there, this increase in help. Sibling-in-law, mother-in-law, father-in-law. We don't see anything from the neighbor. We don't see any jump from the friends, but interesting, the idea of reciprocity. Both neighbor and friends show up when depression becomes severe and it is impossible to hide it any longer. So again, all these rankings are very similar, no matter the kind of support. The more consistent one is from the spouse, from the grandfather and the grandmother, and all the other are do not register, at least at the onset of depression. So in conclusion, and what is for policy? So the perceived lack of support, especially from the baby's father, is linked to higher depression risk in mother more than anything else, more than the support from anything else, even on top of scarcity, in top measuring scarcity in terms of income and in terms of food. Still, feeling the support of the husband seems to be instrumental for women not to feel depression. And the mothers at the threshold of possible depression, they seem to obtain substantial cooperation, especially instrumental and emotionally support from the baby's father. We know that depression is very costly, and we know that this may be an unconscious strategy only when everything else fails. So the policy suggestion for this painful condition that it is felt everywhere in the world would be policies that reduce material adversity, all the policies that support income, all the policies that support income definitely are the number one. But also it points to other strategy rather than giving medication. If the idea is that especially the onset of depression is an important signal that signals the other member in the household that the mother needs help, at the onset, not in the major cases, of course, anything that strengthens family would also be an important policy. Couple therapy that doesn't need to be by trained therapists, could be mediator, could be anything. But it seems that the bond between the mother and the father of the baby is instrumental, and this speaks to the very core of what we are as human beings. We are a cooperative breeding species where we need both. We need everyone to help out to provide for babies.
Thank you so much, Alessandra. Now we're going to have Aaron Abu-Osi, who's an associate professor at the University of Ghana, and he's going to present on his DIWA-funded research in Ghana. I realize we're running just a little bit over, so hopefully everyone can stay for about two to 3 minutes extra for questions at the end.
Thank you very much. Good day to all, and it's a great privilege and a great experience to be part of this summit. I'm presenting on my behalf and on behalf of my colleague, Alexandra Jakubowski from the University of California, Berkeley. Our topic is, it takes a village, encouraging women to use maternal care through community involvement. And this is the outline of our presentation. We are yet to make a real start of our study. According to the World Health Organization, pregnant women are supposed to have at least 8 contacts with qualified healthcare professionals, especially midwives and doctors, in the course of their pregnancy. In Ghana, at least every pregnant woman attends antenatal care at least once, some twice, 3 times, or 4 times. But definitely, we know that they are not able to, many women are not able to attend antenatal clinic for the full scale. And part of the reasons is that women usually start antenatal clinics late. And this is due to traditional beliefs, where a woman can only be declared as having becoming pregnant by the mother-in-law or elders in the community, elderly women in the community. And so most women do not attend the first antenatal clinic. Also, decision as to when the woman should start clinic sometimes is due to the involvement of the mother-in-law or the husband who has the financial power. As a result of all these, and also we have women who are born out of wedlock and they feel shy to attend clinic. So for all these reasons, we see that not all pregnant women are able to attend all the antenatal clinics during the period. And so several interventions to encourage pregnant women to attend clinics usually ignore these traditional factors that serve as barriers for pregnant women to attend clinics. And so our study, we want to address this beyond just the routine efforts that have been taken, including mobile phone, encouraging women to go without trying to address the traditional barriers preventing women from attending clinics. So we decided to take about 51 villages within the catchment population of 6 clinics of the Presbyterian Primary Health Care in the Upper East region of Ghana. And our interventions are that we want to organize community debates. And community debates are meetings by chiefs and opinion leaders and elders of the community on important matters. Health is always one of them. So in these debates, we intend to address the cultural beliefs that discourage women from attending clinics, especially during the first trimester, the first 3 months of pregnancy. And then in the clinics, we randomize all first antenatal attendants and into those that we will call them to remind them, and also those that will visit them at home to encourage them to prepare birth plans with them together with their husbands and mother-in-laws, who all will influence as far as attendance of antenatal clinics are concerned. And so this is the way we want to do our randomization. The 51 villages will be randomized into DEBA villages and non-DEBA villages. So we'll see whether there will be the organizing DEBA to educate them about the importance of attending antenatal clinics, especially during the first trimester, and then addressing the traditional beliefs that serve as barriers will have an effect. And the non-DEBA villages, we will not do that. We will also randomize them, those that will visit them at home, encourage them, involve mother-in-laws, involve husbands in the care of the woman, about birth preparedness and so on. And some of them, we will not visit them at home, apart from phone calls. All right, some will not do phone calls. So we are actually now starting our study, and we are in the process of obtaining ethical clearance and setting up the study with questions and so on. Very soon in this month, we will start with the DEBAs. And in May, we intend to start the recruitment of the first antenatal attendants, and we randomize them, those that will do phone calls and those that will do home visits. And then at the same time, we will also do a baseline surveys to take their social demographic characteristics and other characteristics of all those that are attending antenatal clinic for the first time. And so when they deliver, we will start end-line surveys 3 to 4 weeks after delivery. We will start end-line surveys, and from this as part of the evaluation, And from there, we'll be able to know the impact of our intervention from the end lines of this as we start analyzing the data. So far, this is where we've gotten to. And
Aaron, you just have about 30 seconds to wrap up this final
Great.
slide. Thank you.
Yes, our study has policy implications at the local level, as the local people are very excited about it because of the traditional component. And then, of course, we have also involved the health authorities at the regional level, and we also give them policy briefs. And of course, we also know that it has relevance for the scientific community like us. So thank you so much for your attention.
Thank you, Aaron. Now we'll have a couple minutes of questions for all three presenters. Hopefully everyone can say just a couple minutes to ask their questions. First of all, I see Afua has a question in the chat of whether asking permission from mother-in-laws and husbands before attending ANC is a rural phenomenon, or is it urban?
Come again? Is it the question addressed to me?
Yes, that's
okay. Can you take up the question again?
Yeah, Afua, do you want to unmute and ask your question?
Okay, I've seen the question on the the question is whether asking permission for mother-in-laws and husband before attending ANC is a rural phenomenon or urban. It's a mix. In fact, when we talk of rural and urban in Ghana, it's relative. It depends on, we have big cities like Accra, and then we have other regions where the population is largely rural. So in the Upper East region, for example, it's largely rural with similar belief systems. And so you still see that these traditional beliefs that loom-like and are entrenched still have a lot of influence for the women. Even in Accra, depending on the level of enlightenment, you still have these traditional beliefs that are deep-seated.
Thanks, Aaron. So now we have a question from Abigail for Benjamin to hear a little bit more about the additional intervention arms in your study and why and how you chose them.
The additional intervention.
Yeah, so just to sort of pick that one up. So the basic treatment was a sort of performance-based financial incentive on top of the salary-based payment baseline. And then for the other treatments, we kind of picked measures that would try to counteract the effects of performance-based financial incentive treatment. So we had 2 primes, and in one other treatment, we kind of switched the drug that was incentivized to sort of see if there was something about the drug or really about the incentive. So that the 1 prime was really providing information to participants around the health needs in the area, and those health needs pointed to another medication. So we provided more information about sort of the diarrheal disease prevalence, and the diarrheal disease prevalence means more ORS is needed. So kind of information points to another drug, and then incentivizing the same amoxil to see if that would kind of like counteract that effect. The other treatment called professional norms, we actually got some lines out of the professional guidelines that are kind of issued to all health professionals in Zambia, kind of pretty much say, always be patient regarding, always think of your patients, do what's best for your patients. Had the participants read these primes before they made the decisions. We try to see if that would help to counteract the effects. And we just didn't see that was a counteracting measure at all.
Thanks, Benjamin. For our last minute, I just want to see if there's any questions for Alessandra on her presentation. You can raise your hand and I will unmute you. Okay, it looks like there's a couple more questions in the chat. I think I'm going to share the speaker's emails. That is in the bio list if you want to follow up with them over email. And from now, we'll go ahead and close out the